HASTAM program, Hand Surgery Talent and Mentorship, the Next Generation web series. So today we will have this program from 7 p.m. to 8:30 p.m. The first speaker will be Dr. Darshan Jain. He is a consultant hand and upper limb surgeon and microsurgeon from Sapiens Clinic, Bangalore. Additional Director of Hand and Upper Limb Surgery and Microsurgeon, Fortis Hospitals, Bangalore. He's done his MS Ortho, MNAMS, FNB in Hand and Microsurgery, Clinical Fellow in Hand Surgery from National University Hospital, Singapore. And he's done his PG Diploma in Tissue Banking and in Hospital and Health Management. And the moderator for the first session will be Dr. Abhijeet Wahegaonkar, very popular person and well known. But however, I'll introduce him. He is the Director of Hand Surgery at Sahyadri Hospitals, Pune, and the Director of Upper Limb Hand and Microvascular Reconstructive Surgery Fellowship Program. And he's a consultant brachial plexus and peripheral nerve surgeon. Fellow from the Hand and Microvascular Reconstructive Surgery from Louisville, Johann Wolfgang University, and University of Geneva, Switzerland. He's a fellow of brachial plexus and peripheral nerve surgery hand surgery from Japan, and a fellow of shoulder surgery from France, and FACS. He's a fellow of the American College of Surgeons. Wow, that's very impressive. And the first speaker, Dr. Darshan Jain, will be talking on a very contemporary topic that people want to know about but are a little vague about. Basics of wrist arthroscopy, a bird's eye view. Over to the moderator, sir.
Thank you. Thank you very much, sir, for that generous introduction for both of us. Very humbled and very grateful to the ISSH. This is a fantastic initiative of the ISSH to learn from each other, each one teach one kind of a program. And I'm very glad that Dr. Darshan Jain has been selected for this talk. I can't think of anyone who will do justice to this topic more than Darshan Jain would. So over to you, Darshan, and we would be very eager to hear from you about the basics of wrist arthroscopy, a bird's eye view. Thank you so much.
Good evening, El. Good evening.
I'm sorry, Darshan, to interrupt. May I request everyone to please keep their mics on mute so that there is no background noise while the webinar is on. Humble request, please. Thank you very much. Thank you.
Can I start?
Yes, please. Yes, please. Thank you.
Good evening. Thank you, sir, GK sir, for this opportunity, and thank you, ISSH, for providing this platform, beautiful platform to exchange our experience on various topics. And wrist arthroscopy is one such topic which is very close to my heart, and we've been doing from quite some time. So this talk mainly aims at getting introduced to the wrist arthroscopy. What are the nuances, what are the basics of these things, and the portals, and what procedures can be done. So hope at the end of the talk, there will be some light in the shoulder and the wrist joint. So this is what we would want to know at the end of this presentation. So outline of my talk is going to be on the equipments, what we use, and the basic techniques, the portals, what we do, and the conditions of the arthroscopic with corroborations of some of these conditions. So typically the setup is, this is how a setup of a wrist arthroscopy is going to be. So you need a hand table with a patient in supine position and the surgeon towards the head end, because all are much or the most commonly performed portals are on the dorsum side of the wrist. That is where we want to stand, and the anesthetist on the other side, and with the assistant on the opposite side. And towards the opposite side, on the contralateral side, you have the tower, you have the light source, and the shaver, whichever is important. And sometimes you need to keep one of those Mayo trolley to keep all your instruments, because these instruments are very fine. You need to be gentle in handling them. So this was our initial setup when we started in, means it's been almost 11 years since we are doing wrist arthroscopy. This was some of the custom made traction towers which we started it. That is the head end. And when you see that, generally this is how we started one. But there are various types of traction which are available. I'll be just going through them. So you have an alternate option of giving a simple traction where the board is there and you use a traction device, and generally a traction of 3 to 5 kilos is what we usually give. So this is example, for example, this is a shoulder traction tower which we are using, and then a board on that where our fingers are testing. Please avoid tractions which have adhesive tapes on the fingers. They are not good unless your procedure is going to just finish off in just maybe half an hour or something, because a lot of times the setup takes times. That is very important, because if you don't have a proper setup, or if you're not your sir means your OT people are not aware of these setup, then you are going to end up wasting a lot of time. So this is one such way of doing this. Another variety. So this is another traction, because traction is so essential in all these procedures, so that if you don't have an adequate traction, you cannot perform, and it's frustrating. So this is another variety of traction which have been, means practically we have used almost all varieties of traction. This is more of a hydraulic type. You can see that. So that is how it works. It's got a clip where you release the hydraulic tension and then you can adjust it whatever. This also acts as a shoulder support as well. So this can be used there. And you have various angles can be fixed, which is very helpful for this. And you can see that this is what the traction device, how you attach it to that frame. So this is what is a finger traction which can be provided. So this is one such. This is one of the companies from Arthrix which provides this. So once it is attached, this is how it works. So you can totally live, it's a totally sterile condition, and you're not dependent on an external support or an OT technician. That's the best part, because when you're doing entire framework will be on a sterile support. So these are the other traction. Similar way you can attach it. Finger traps are used here. Again, this has got a gauge here, the blue. This is Eyeview, which gives you the traction there. And this is another Arthrix type of device where another board can be used. So this is another company. So this is a ConMed traction device. Again, this is entirely sterile, so you don't have to depend on because a lot of times when you depend on others, it's difficult. This is the first generation traction of the ConMed. And currently we are using this, the latest one with newer type of ConMed traction. We are using this as well. So we have been practically using all these multiple varieties. These are some of the finger traps which are available, where you can adjust the tension. Even the smallest of the thin fingers also can be fixed with this. So this helps us to do a lot of maneuvers there. So let's go to the other essentials. What you need: the marker pen, because before you start, you need to mark the topography. Is very important for these surgeries. 18 gauge or a 21 gauge needle, a 5 ml syringe, grasper, punch, and a shaver is very important for this, RS plus or minus ablator. Gravity flow is sufficient. You don't require a pump, but a shaver is very critical for this managing. And especially a small shaver is very helpful to manage this, because larger shavers are very difficult to hold and do our procedures. So you could use 1.9, 2.4 or 2.7. Most commonly, many of them start with either 2.4 or 2.7. 1.9 is very good, but it's very delicate, and very often when you start, avoid using this, because there's a high chance that you're going to break it. You need to have a constant monitoring when you're doing it. So these are the markings which you need to do. So you have generally.
Hello,
So
yeah, I've muted
yeah,
you.
thank you.
Yes, sir. Thank you.
So this is what, as soon as you put on the traction, and these surface markings are better to be done once you put the traction on, because they generally tend to shift a little bit by a few millimeters, but it is very critical. So once you put on the traction, exsanguinate and put on the traction, you need to mark the most important part as the lissus tubercle. And these are the commonly used portals. The most commonly portals are the radiocarpal portal and a midcarpal portal. So you look wrist as a two floor. Means one is a ground floor, that's a radiocarpal joint, and the midcarpal as a first floor. So this is how it is useful. You could also use a DRUJ scope, but I think we will just stick to this basics as of now. So the radiocarpal portal or the 3-4 portal is most commonly used. So once you palpate the listus tubercle, then just above that is what is you find that's a workhorse. So you need to get a very good 3-4 portal. That's the key, because you will be doing much of your procedures through that portal. The other portal will be the 6R portal, which you establish. That is under vision, you do generally the 6R portal. The rest are the MCR and the MCO. That's a midcarpal radial portal, and the MCU midcarpal ulnar portal. So as I mentioned, 3-4 portal is just 1 centimeter distal to the listus tubercle. And 4-5 portal is rarely used, in line with the fourth 3-4 means slightly in line with the fourth metacarpal. 6R portal is done under vision and 5 millimeter distal to the dorsal part of the TFCC. It's a main working portal. So you should be careful of these cutaneous nerve, which are commonly, especially the dorsal branch of the ulnar nerve is one thing which we often see. They would have injured, especially whenever a surgical procedure is planned for a TFCC. So making a portal is very critical. Once you palpate this, you need to just make a nick, ideally with a 15 number blade, because don't plunge your knife unlike other scopies, and you need to make a small opening with a mosquito and then get inside. So this is how, once you do that, a small incision is done. Close your artery and open gently, push it inside. And this is a 2.4 scope which I'm using. So once you do that, once the light source, you turn it, and mind you, this is the way to hold the scope, because your light source need to be in your palm, unlike the other scopy. When you do the rest of the scopies, you want it to be on the top, whereas your light source is and the camera rests on the first web space. So you introduce your needle there, and that's how you can see confirm the making of the 6R portal. These are the other portals, the SCT portal on the radial margin of the index metacarpal. So also one should remember the angle you introduce, because these are tight compartments. One need to be careful how you introduce. So it has to be an inclination when you introduce these scopes. And the box concept, which mentioned by Bain, is nothing but a triangulation trick, which you get used to hang, because how you orient your camera and how you orient your light source. So that's how, and visualize that as a box, because it's more of a flat. The radiocarpal joint is more of a flat joint, whereas the midcarpal joint is more of a curved structure. And also a typical anatomical visualization. When you put a scope inside, these are the things which you visualize. That is a RSC ligament. That is a radioscaphocapitate ligament is one of them. The other one is the ligament of test 2, or the RSL ligament. Then these are the two other ligaments which will be visualized. That's the ulnotriquital and ulnolunate, and the TFCC. So if you have if you have in your OT procedure list this one, it's easy to draw diagrams and mark up for every surgeries when you do this. That's easier procedure written. So let's go through the radiocarpal portal first. So this is how it's a flat joint, whereas you can see, whereas the midcarpal joint is more of a curved shape. That means you have to be careful about seeing your joint, how you turn your scope along that. So this is how you hold. Don't keep the light source above, keep it in your palm and rest the camera on your web space. That's easier way to do. And keep your finger on the dorsum of the hand so that you can control your movement of the camera in and out of the joint. Midcarpal portal, these are the two MCU and MCR portals are the most common. And the depth of the midcarpal joint is less than the radiocarpal because the joint is quite tighter, so you need to be careful. Midcarpal radial portal is 1 centimeter distal to the 3-4 portal in line with the third metacarpal. And MCU portal is 1 to 1.5 centimeter above the 4-5 portal and the fourth corner intersection, and which is also. So let's go to the basics of a diagnostic round of this wrist arthroscopy when you see. So this is the radiocarpal joint. You are viewing through the 3-4 portal and the diagnostic round of. So as soon as this is the RSC ligament, the top on the scaphoid. This is a dry scopy. You could do a dry scopy or through the fluid insufflation. Much of the time you can do a lot of procedures through the dry scopy itself. That's a long radiolunate ligament. That's a ligament of test 2. Sorry. So once you turn towards the ulnar side, you can see the TFCC on this side. This is the TFCC and this is the radial side, sorry. Going towards the radial side. This is the scaphoid, the proximal pole of the scaphoid. You can go all along up to the dorsal, means on the radial side. So when you turn towards, going towards ulnar side, so you need to turn your scope and your light source as well to visualize this. That's a TFCC which you can see. That's a needle which you introduced. This is a TFCC. That's a 6R portal what we have made. So next is weaving to the mid-carpal portal. That's a MCR portal and the diagnostic round you can see. As soon as you, as I told, this is a curve, an arc. So you cannot move your scope horizontally. You need to do on as a curve. That's a lunate. Then moving towards the ulnar side. That's a LT interval. That's a triquetrum and the lunate. Going back towards the radial side. That's a capitate what you see, scaphoid and the lunate. So these are the various conditions one wants to know how does it look and what is the possibilities of managing. These are the few conditions: TFCC tears, synovitis, chondral lesions, ligament injuries, ganglions, scaphoid non-union, ulnar impaction, ulnar styloid impingement, Keen box, etc. Some of the basic. So let me go through one of the simpler ones like the arthroscopy assisted distal radius fractures, or more often you can see, but it's not easier to do. But one needs to remember, whenever we see a comminuted fracture, these are the boundaries where the ligaments are attached at the periphery, but some of these on the which are on the center is what we generally tend to miss out or will not be able to reduce. This is about arthroscopy assisted distal. So this is you can see a distal radius fracture where there's a die punch or a significant comminution in this. So when you note the CT, there is a lot of fragments which are comminuted and also impacted fragments. This is an ideal case or the blowout type of fracture or explosion type of fractures which we are generally managed with this one. This is a dorsal, this is volar, and that's a radial side. You are viewing through the 6R portal. So you elevate these fragments with a probe once it's on the traction. Temporarily, you can stabilize with a plate outside. Don't tighten those screws. See, this fragment is totally rotated almost 180 degrees. That's a cartilage which was upside down, which we have a high chance when we are doing an internal fixation, we miss out these fragments. So you reduce that, bring it to such a big gap and the crater-like thing, you bring it up, match this thing, and it's just like a jigsaw puzzle. You need to arrange them. Once you bring all these structures to it, your final fixation is done from outside. So this is how now a smooth surface is obtained. Once this is done, you can just drain the fluid out, and this is how you get a fixation. So the post-operatively, this is how a good articular surface is maintained, and you could use a couple of KYs to stabilize, maintain the reduction. The advantages is faster rehab and better restoration of articular surface. This is 6 weeks after the surgery. You could take out the wires by 3 to 4 weeks, and then you can get this range of movement. This is another case where you can see a TFCC tear. So you can see a dorsal tear, then the dorsal capsular tear. This is typically where there's small subluxation of the distal ulna. You can see once this is visualizing for 3-4 portal, you can see that's like so floppy, and that's a big tear on the dorsal rim of the TFCC. You freshen those edges. You could use either a PDS or a fiber wire to repair that. Freshen that edges, and then you start introducing those PDS through the needles. The first stitch, this is the first stitch which you use. These are simple sutures. There are various configurations you can try, but I wanted to show you some of the simpler ways of handling this. This is the first stitch which you bring it to the dorsum capsule. You see the tension has started restoring. So similarly, you can pass the second. This is the second stitch which you pass. And finally, the third stitch. So almost 3 sutures we had to pass it through the TFCC on the dorsum capsular or the TFCC part, which was used to stabilize this. So once you repair this, you tighten this one after the other slowly and reduce the traction and then tighten it. You can see the tension is restored, and immobilize it for 4 weeks. And after 4 weeks, you start mobilization exercises. So the other procedures which we do is the SL ligament. Just before we go on, I just wanted to show you how the SL ligament appears. This is how in the radiocarpal joint it appears. This is how you have to assess from the mid-carpal portal. Actually, you see it from either MCR or the MCU. So you should not be able to pass the probe to, this is a normal type. It should be very tight. Volar side you may be able to pass, but on the mid segment and the dorsal part, you cannot insinuate your probe between the scaphoid and the lunate. This is how a normal part looks. Whereas a partial injury, this is how it looks. There is some gap. Once you try to manipulate from outside, apply some pressure to the distal tuberosity, there is small opening. That is the partial SL injuries. And this is a complete SL injury where it's a big gap. You can see the radiocarpal joint from the midcarpal scope. So that's how the injury is. So this is an circumferential procedure where we make arthroscopy assisted, is not entirely arthroscopic, but arthroscopic assisted procedure. You make two bony tunnels across the scaphoid and lunate, and then you do the SL reconstruction. So typically this individual had a gap of injury and SL injury for almost some 9 months. So once you see this, the MRI also shows this thing. This is a radiocarpal portal. You can see there's a flap like tissue on the SL injury. This is what you can see from the midcarpal portal. You can easily pass the scope, and so I had to debride some fibrous tissue which was present there. Once you debride that, then you start assessing. You make two tunnels in one through the scaphoid and one through the lunate. So this is the palmaris longus graft I'm using. This is a lasso loop which I'm trying to take it through the lunate and come circumferentially along with this. So you tighten that on the dorsum of the wrist, and that's how it appears. Once the scope is done, then you see the gap. This is the interval, typical interval. After that, you introduce your scope again and check. So it's well reduced, and there's a very airtight closure between the SL interval. That shows that the repair is good. So there are other conditions which you can see. This is a dorsal ganglion. You can see the dorsal. This is the ganglion which you are visualizing to the 6R portal, and your camera is there. So 3-4 portal, and your arthroscope, the shaver is introduced to the 6R portal. You could remove this ganglion completely through the shaver. It helps also in visualizing the associated ligamentous injury. That's the advantage. And also bump is not replaced by a big scar when you want to excise a ganglion. That's the advantage of doing arthroscopic ganglion excision. You also need to remember that there could be septations where you could, and also the volar ganglion also can be excised. Once you shave it, that's the ganglion you are seeing. I'm pressing it from outside, and you can see from the radiocarpal portal. So that's the fluid which is coming through the ganglion to the radiocarpal joint, which I'm shaving it out. There are various other procedures. This is the arthroscopy assisted scaphoid non-union. Typically the procedure involves, these are the midcarpal portals and the radiocarpal portal you use. And you fill that area with a bone graft arthroscopically itself, and then stabilize with a screw. So this is a scaphoid non-union. You can see in oblique views, this is the non-union site well seen. The sclerosed ends, however, there was no cyst. So you use a traction device, and then you identify the non-union site. That's the non-union site which is I'm trying to probe through. Then you use a shaver and cure it and clear off all the fibrous tissue. Once you clear, this is the two ends. That's the distal part and the volar part and the proximal part. You pack it with the bone graft. Once you stabilize that, you can stabilize with the screws. There's another wafer resection which you do. A positive ulnar variance, you can see this here on the affected side. This is the normal side, and also edematous changes in the triquetrum. Do you have another minute? I've almost reached this thing.
Yeah, please go ahead.
Yes. So this is the TFCC which you need to the excised because there was some injury on that, you could either go sub underneath the TFCC or through the TFCC itself, because that's a central tear you need to make it. Then you use burrs and curettes. That's the burr which we are using, and take off the small part of the ulna which is causing impaction. And also you need to confirm with the intraoperatively with the CM. That will be ideal. Although this procedure looks simple, it's not. It's sometimes a lot of mistakes can happen where you may not be able to excise properly. You will have to open and do it sometimes. This is the post-operative. This is the part which was resected because that is the one which was causing the kissing lesion. So there are various options, means many more things which can be done, but I thought these were something which gives you an insight. And I would, before I conclude, I would also request you to, if at all you guys are interested, there's a cadaveric course being conducted in Bangalore on 16th and 17th of May under the aegis of ISSH as well. So it's the first day will be on exposure, second talk, and second day will be on all cadaveric. These are the faculty which we are having, both from India and abroad. Looking forward for it. Thank you very much.
Uh, Thank you very much, Darshan, for that wonderful talk with a lot of focus on the basics and the intricacies, also the advanced aspect of arthroscopy of the wrist. And thank you for sticking to the time. Um, I don't think I have much to add to all that you have said, except for the fact that I think it is very desirable for anyone who wants to make a foray in wrist arthroscopy. It is desirable to, kind of do a cadaver workshop first so that you get oriented and attuned to wrist arthroscopy techniques. The instruments are quite expensive, the scopes are quite expensive. And I think the commonest problem that anyone would perhaps have and would perhaps deter him from doing any wrist arthroscopy in his career is breakage. And it's a heartbreaking event to have your scope break. So, taking proper care of these delicate instruments, knowing the portals to avoid any injury to the deeper structures, and also to kind of orient yourself to the arthroscopic anatomy with triangulation. So, a lot of times there is a common feeling that if you've been doing shoulder and knee arthroscopy, jumping on to performing a wrist arthroscopy is just a cinch, but it's not, because it's a very shallow joint with too many anatomical landmarks, too many things crowded into a very small space. So I would really encourage people to kind of have all the instruments ready, the training, the infrastructure to be able to undertake wrist arthroscopy in a successful manner. Uh, Perhaps one of the most common question that I'm asked in so many cadaver courses that we conduct is that can we use a Chinese scope? And I remember Professor Bob Ackland, and I'm sure that all of the seniors, GK sir would agree. So Bob Ackland was very famous for his aphorisms, and one of his aphorisms was, "If you can't see it, you can't do it." This applied to microsurgery, but I take the liberty of extending it to arthroscopy. And I think the same holds true whether you're doing an open surgery, whether you're doing a microscopic surgery, or you're doing an arthroscopy. If you can't see it, you can't do it. And my very own experience when I started wrist arthroscopy was with a Chinese-made arthroscope. And with all due respect to everyone, I just abandoned it because the clarity of vision, the kind of HD nature of the vision. So, in fact, if you were to look at it, we are all microsurgeons. Arthroscopy is also articular microsurgery. You are able to see everything with magnification and very high resolution. And if you have good optics, good instrumentation, you will just enjoy the work. So I encourage everyone who is interested to, kind of really use this kind of platform. There are a lot of experts in our group, a lot of people who are willing to share their knowledge and expertise, to interact, to talk, and everyone can learn this technique and inculcate this in their daily practice to expand their scope of practice. And not only that, but perhaps to serve our patients better. So, although this sounds too philosophical, but I think over time, people will agree with what I'm saying, and they will also perhaps share the vision. Nevertheless, there are certain questions now, Darshan, that are in the chat box, and if I may kind of pose these questions to you
Yeah.
and you can answer them. So, one of the questions is from Dr. Chaurasia sir, and the question is: doesn't cartilage destruction after wafer resection cause symptoms? Would you like to answer that
Yeah.
question, please?
Usually, a resection is of almost off. We take it off almost 3 millimeters. Assuring means that is the minimum requirement we take, 2 to 3 millimeters. And once you excise that much, very unlikely to have. And you cannot use wafer resection for all cases. That's a limitation because, or else, if at all anything around 3 millimeter resection, so you need to compare it preoperatively with the opposite side, that your variance correction should not exceed 3 millimeters. If at all, if it exceeds, then if you do this procedure, then they will definitely, the cartilage removal can damage the joint further. So ensure that you are doing only for subtle deform means positive ulnar variance, and also after giving a trial of conservative treatment. That's very important because many of them do subside with this procedures, with steroids or immobilization. They do help.
Darshan, if I may add, with your permission,
Yes.
an expansion to this topic while we are on it is that so vapor resection is usually indicated when the DRG is stable and there is an ulna positive and there is an ulnocarpal abutment or a conflict, provided the TFCC also is perforated. If it is thinned out, you might have to create that perforation to be able to reach the head of the ulna for your resection. In my books, if there is a DRG instability along with an ulna positive, we perform a diagnostic wrist arthroscopy, and then we go ahead with performing ulnar shortening osteotomy, the standard open procedure. However, if the DRG is stable, if there is ulnocarpal abutment, so I'm talking about type 2B onwards, if there is a TFCC perforation, then you can reach the head of the ulna through that perforation to perform a resection. And just about adequate resection has to be done until you are at the level of the distal margin of the sigmoid notch. Would you agree with that, Darshan, or do you have
Yeah.
any other take on this?
Yeah. No, that's perfect.
Right? So wonderful. There's one more question from GK sir. Is there much pain after the procedure and how do you handle it?
The beauty of this arthroscopy is minimal pain. In fact, many of them do perform only with the wrist block itself, so there's not much of a pain there.
And I concur. I think wrist arthroscopy, like any other procedure, uh, if you, I think for the first 24 to 48 hours is all that is required for pain management. And after that, we encourage rehab and range of motion exercises, and that is usually very well tolerated. The next question again by GK sir is if a youngster wants to do wrist arthroscopy, is it necessary to learn shoulder arthroscopy first?
Definitely not. So that's not that way. Actually, one has to be more well versed with a wrist pathologist to do a wrist arthroscopy, unlike what many scopy guys think that once if you're comfortable doing shoulder and knee and you can do a good job here. But definitely a triangulation component, it helps you in a skill set because it's an added skill set compared to just like your microsurgery, you're seeing in somewhere and operating. So partly it can help, but overall it's not because that's a larger joint and here our movement is only with the fingers and the wrist, whereas when we are doing shoulder scopy we move our wrist, shoulder and elbow as a surgeon, so the finer movements are not so it's not mandatory that you need to know to be doing shoulder scopy.
Yeah, and especially in today's times, I guess when there are so many wonderful cadaver workshops, you can actually do one of a focused workshop and then kind of. I think more than shoulder arthroscopy or knee arthroscopy, it is the orientation that is more important. Would you agree, Darshan? The
Yeah.
triangulation techniques
Yes. Yes.
and the orientation, which is much, much more important and pertinent rather than being an arthroscopist for other joints. There is one more question for you, sir, Darshan, from Dr. Chaurasia, sir. And the question is ulnar shortening a better option in shortening of more than 3 millimeters? And what are your thoughts and your take on it, please?
Yeah, definitely. If it is more than 3 millimeters, I would recommend ulnar shortening on for two reasons. One is the because if you want to go beyond 3 millimeters, you will end up reaching a DRUJ joint, which is not good because that can itself procedure per se can damage and it can cause pain. Second thing is there are the ligaments become taut when you do a shortening of the ulna. That's the means ulnocarpal ligaments become taut when you do ulnar shortening osteotomy, which also helps and pain relief and better dynamics of the wrist.
Great. The next question for you from Dr. Balaji is can you shed some light on the management of a dorsal wrist ganglion and why would an arthroscopy be necessary to ensure no recurrence?
See, rather than necessary is a very difficult word. It's not necessary to ensure because it helps us to see associated SL lesions or the cysts in the SL, this thing. Rather, arthroscopy, I would say MRI is necessary if at all you are going for an arthroscopic resection of the ganglion because a lot of times you would miss some intraseptations of the ganglion and you might think you have resected that and that can cause recurrence. So MRI is more important than an arthroscopy to prevent recurrence.
Great. Actually, if I may add, when we counsel our patients for an arthroscopic ganglion cyst excision, that we always tell them that this cyst might just be a sentinel to an underlying ligament injury, the scapholunate ligament injury. And if at all that is the case, then we are in a better position to address it, repair the ligament injury along with excision of the ganglion cyst. So, do you think that is also your experience?
Yeah, definitely. Apart from that, you could also have some synovitis component whenever these ganglions are actually there. That is the cause of pain rather than the ganglion per se. The synovitis associated with it is the key because we consistently see synovitis around these pedicles and this thing when we put a scope, which we don't track it when you're seeing from outside. That's extra capsula when you're working. You may not notice that synovitis so much because you don't want to open the joint so much rather than you just go to the root. Whereas when you put a camera, you will be surprised that so much of synovitis around that.
The next question from GK sir again is how much does it cost to set up a wrist arthroscopy unit from scratch with the best instruments that you would recommend?
Uh,
And I'll also pose the next question for you. This is from Dr. Radhesh. And the question is what is your take on the use of midcarpal portals for resection of dorsal ganglion?
Okay. So from the scratch is generally because many of us, many of the units would have a basic instruments like the camera and the means camera will be there and the shaver system also could be there. So you need to buy a reasonably good traction and the scope is very important and the small shaver if you can afford because some of these big shavers have a small adapters as well. So at least you can think of an approximate investment of maybe minimum investment of around 8 lakhs or something. That would be reasonable, I feel, because if at all your orthopedic colleagues have already the other things, you could share and use it. So scope is one thing which you need to buy and a small traction unit and if possible a small shaver. Going forward, if you want, there is a lot of luxury there. You can even invest up to 40 lakhs to this thing if you want the best of the lot. But this much is, should be good enough to start a unit, start your work. And the second other question by Dr. Radesh that your take on midcarpal portals for a section dorsal ganglion. That's what the MRI will tell us. It's important if at all you feel the pedicle is coming from the SL, it's worthwhile. You have to look into the midcarpal joint because you or else you'll miss the SL injuries as well. So it is important to see the midcarpal joint as well.
In fact, Professor Christoph Mathuna, he always used to tell, and he still does, that it is very, very, it is a mistake to assume that the ganglion is arising from the radiocarpal joint. It almost always arises from the midcarpal, the dorsal aspect of the scapholunate ligament, and then it spreads around. So if you are staying in the radiocarpal and excising the cyst, you're missing out on the actual stalk of the cyst, and the chances of recurrence are higher. So it is always advisable to go through the midcarpal joint, in which case your primary viewing portal becomes the ulnar midcarpal portal, and your working portal will be the radial midcarpal portal. Excise the cyst. It is always advisable to avoid damaging the dorsal intercarpal ligament and create a 1 by 1 millimeter window in the dorsal capsule to kind of create a marsupialization and prevent recurrence of the cyst. Would you agree with that, Darshan?
Yes, yeah, definitely.
Right. So, um, are there any other questions?
There is one more
There is
question,
one
sir.
more question by Dr. Ramani. What is the best option for dorsal wrist ganglion, open or with arthroscopy? Or when do you recommend arthroscopy?
Okay. Definitely open is the most commonly performed surgeries. I mean, if it is persistent and if we find if you have a suspicious of SL injury, is that is one thing you would we would definitely want to recommend an arthroscopy, or else you could manage with majority of them with a open itself. But as I told, the advantage here is also the scar. You don't replace a bump with a scar, whereas here there's hardly, if you're using 1.9 scope, there's hardly any scar. That's a major advantage because many of these dorsal ganglions also are, or almost at least 50% do come with the cosmetic issues rather than only a pain. So these two addresses, if at all you have the skill set, I think I would suggest ganglion is not the most common surgery in my practice to do for wrist arthroscopy as well, but it is one of the ways to you can deal with it.
Can I ask a question?
Yes, sir.
Now, supposing a youngster who's just starting off his wrist arthroscopy
Yes, sir.
asks you which would be the easiest and most rewarding case for wrist arthroscopy to start off, what
Okay.
would your answer be, Dr. Darshan?
So the simplest case, what they can start with is actually synovectomy, sir. Rheumatoid patients are quite often you can see. So you are not going with a major task of repairing or this thing because you need to get the orientation. Rheumatoid synovectomy is a very good procedure, in fact, because the synovectomy gives a phenomenal relief than a steroid injection. There is a lot of literature with when you use a steroid, there is thinning of the cartilage as well, which is not documented well. The minute you give 2 or 3 shots, the wrist joint space goes off. Whereas when you do a arthroscope, the wrist joint lasts very long because you're not damaging it, and you can do minimal work and try to get your orientation through that because many of the TFCC is not at all a case to do a arthroscope as a first because if you do any MRI, even my MRI, they'll show TFCC tear. Your clinical diagnosis is very important before you venture on a TFCC tear because that is one thing which I'm scared and many people abuse that. I mean, start doing for a TFCC tears.
Thank you. That's a
Can
nice.
I
Dr. Abhijeet?
can I add something?
Yeah.
Yes, sir.
Yes.
To my mind, I think the easiest case that I would perhaps think of doing to begin wrist arthroscopy is ulnar-sided wrist pain in a patient who has a stable DRUJ and perhaps who has failed conservative treatment. So even with rheumatoid arthritis, Darshan rightly said, in most of the cases it might not be too difficult, but the synovitis itself may preclude proper visualization. There is too much of red synovitis, and if you try to kind of shave off the synovitis to have a proper visualization, may cause bleeding and perhaps cause kind of a difficulty in performing an arthroscopy. So maybe undecided wrist pain with a stable DROJ usually indicates a central tear of the TFCC without much of synovitis. It's a pristine joint. Visualization becomes easy, and therefore, to my mind, I think that is perhaps a better kind of an opportunity to start your wrist arthroscopy foray. Darshan, would you agree, or do you have any other different take on
Unless-sided
this?
wrist pain, I would not subject to surgery unless my diagnosis is clear because they are the most unhappy lot and they'll be roaming around. So I would definitely not suggest that because you are recommending a surgery for some pain, and if they don't find a relief, then he's going to come back to us. Whereas synovectomy, definitely, it might be a little bit difficult, but definitely they'll find some relief. They'll be happy with it. So I would try with
All
this.
right, thank you. Thank you.
There is
There is one question. Have you incorporated the table lift test described by Lucian Marcovici?
The table lift test, not always this thing. More than anything, my time frame and the way the injury is what most important. I try to take. Not always. That's not the criteria for me to diagnose these or in my all my ulnar sided wrist pain.
So I would also want to add there is not one single test that is completely diagnostic or completely rules out. I think you have to really rely on a very good history taking, perform each and every test, and then kind of come to a diagnosis clinically and couple that with your radiological investigations. Do you think that's a good way to kind of go about the diagnosis,
Yes,
Darshan?
definitely, definitely.